Okay, thank you very much. I'd like to thank Dr. Ramon and Klotz for the kind invitation to give a little bit of a pathological perspective at this symposium. It's a complex topic. I only have 10 minutes. I've learned from my brief period in Israel that Israelis speak quickly, so that's how I'm going to get through this talk, by speaking fairly quickly. A very provocative part of the talk is this issue of Gleason pattern 3, or at least some Gleason patterns 3 may no longer be considered cancer. The subtitle in this talk will be Gleason on Shifting Sands, so to speak. So a little bit of what I plan to do, just cover a little bit of the historical perspectives, talk about where we are in terms of Gleason grading in 2012, is Gleason pattern 3 cancer, and the future son of Gleason. So Dr. Gleason created this system back in the 1960s, about 45 years ago, a very powerful system based initially on the work done at NIH with some of the androgen deprivation work related to diethylstilbestrol and orchidectomy, developing these patterns of Gleason that you see on the slide below. There's 9 different patterns that he arranged in the classic Gleason diagram. And to this day, these Gleason patterns are still very useful in classifying what the pathologist sees and looking down the microscope in cases of prostate cancer. So this system has been very successful, and mainly because it's something that's based on a low-power architecture for the pathologist. It doesn't take a lot of time, and this very nice diagram, which virtually all pathologists throughout the world have this by their microscope and can easily compare their cases they're looking at under the microscope with the classic Gleason diagram. And you can see on the Gleason diagram that there are 5 grades, but within the grades there's some heterogeneity as well. You can see, for instance, in 3 there's A, B, and C. 4 there's an A, B, and 5 there's an A and B as well. And those were the original 9 patterns that Gleason came up with. So a very powerful system, and it's being adapted by virtually all major organizations throughout the world, College of American Pathologists, international societies, etc. And you can see when you look at the data that's out there, there's good level 1 data related to whether it's radiation you're talking about or surgical treatment, that this is a very, very powerful system that stratifies. This is the classical Gleason system. So what's happened, though? What's happened between the 1960s and the current time is that there's been a big change in practice. We've gone from thick core biopsies to thin core biopsies. There's less TURs, enucleations, and a great number of more radical prostatectomies that have been done in modern times. So back in 2005 in Boston, we had a meeting of the International Society of Urological Pathology where we came up with a modification of the Gleason system based on modern-day practice with thin core biopsy. And there was a lot of things that we discussed at this meeting, but I'm just going to highlight some of the most important ones. And one of the most important ones is that you don't diagnose Gleason patterns 1 and 2 when it comes to needle biopsies. They're virtually non-existent in that category. And even in other situations like radical prostates and TURs are relatively uncommon. So the Gleason system in needle biopsy starts at Gleason 6, 3, and goes upwards from there. So that was a very important thing that we looked at. The other thing that we looked at was within the Gleason 3 category, there's a lot of heterogeneity. As I said, there's 3 different sub-patterns of Gleason 3. And what happened at that meeting is we decided to move some of these patterns around. So we moved a lot of the cribriform stuff down in Gleason 4, and some of these poorly formed glands over here we moved down as well. What that resulted in is a modified Gleason scoring chart that you can see over on the right-hand side. Now, here's our Gleason 3 now. We still have kept, in 2005, we still kept a few of these cribriform structures within Gleason 3. We still have a few very small acini, discrete acini in 3, but the rest of the stuff has been put in 4. So there's been this change in the definition of the Gleason system, if you will. So this has led to significant upgrading effects. So there's been a ton of trials and other studies done by the pathology community, by the urology community since 2005. Just a few of them just to show what's happened as a result of that 2005 consensus conference. This is some work done by Lars Egvad and Helpap in Sweden and Germany, showing this upgrading effect. You can see that there's a reduction now with the modern Gleason system, going from 48% Gleason 6 to 22%, Gleason 7 going from 26 to 68%. And this has resulted in improvement in the rates of correlation between needle biopsies and radical prostatectomy Gleason scores. This is a study from Japan, looking at going from 6 to 7A. This is 3 plus 4, going from 7A to 7B, 3 plus 4 to 4 plus 3. and from 7A to 8 and 7B to 8, showing about a third of the cases now are upgraded using the modified Gleason system. And this, of course, has made a big change in the D'Amico classification as well. You can see going up from 31% high grade to 41% high grade. So this has a very significant upgrading effect. The other thing that's been done since 2005 Consensus Conference has been some reproducibility studies, and I think pathologists are pretty pleased now that, in fact, that while at the end of the 2005 we kept a few of these cribriform structures within Gleason pattern 3, these rounded ones that are very uniform, these more irregular ones up at the top were Gleason 4. I think the way we practice now is that anything that's cribriform gets put up into Gleason 4. So what's happened now is we've had further shifting in the Gleason system. So we have the original classic Gleason, we have the 2005 ISUP modified, and Jonathan Epstein and Peter Humphrey have recently published this diagram, which basically removes all cribriform structures at all from the Gleason 3 category and puts them up into 4, and moves more of these poorly formed glands up into 4 as well. So this is a sort of system, this purification of Gleason 3, if you will, is what's going on right now. Now, this has left a lot of heterogeneity in Gleason 4. And in fact, when you look in there, there's several different patterns that are probably of statistical significance in terms of outcome. And we have some early data from the big radar trial, which is going on in Australia and New Zealand, a radiation trial, indicating that, in fact, there are patterns in Gleason 4 that are of significant value in terms of outcome. So I think there'll be further work done in that. Well, let's just focus a little bit on this Gleason 3 category. So the question that Laurie has asked me to talk about now is Gleason 3 cancer or not? And that really depends on this issue of your perception of the word cancer as well. You have the pathologist on the right-hand side who is actually looking down the microscope and using criteria that are histological criteria, marker criteria, to come up with a diagnosis of not cancer. We use terms like carcinoma, sarcoma, traditional classification terms. On the other side, we have the patient faced with this word cancer is, say, oh my God, I have cancer. Is this something that's going to kill me? Am I going to be dying some horrific death, wasting away and dying of metastatic disease? Then you have your clinician in the middle has to deal with this information and translate the information from the pathologist in the laboratory to the patient to make some sense out of it. So is Gleason pattern 3 cancer? Well, first of all, cancer is an imprecise term representing hundreds of diseases. Gleason pattern 3 is a carcinoma. There's no denying in the pathology world that the criteria are there from the point of view of your morphological criteria, your marker criteria with respect to markers such as basal cell markers, racemase, that it is a carcinoma. There is at least some limited loss of growth control of that proliferation. There's neoacinar formation. Can a pure Gleason 3 metastasize? I'm not aware of a pure Gleason 3 case that's actually metastasized to regional lymph nodes. So perhaps not all Gleason 3s then are cancers in that sense that the patient thinks about cancers. And there's other examples like this in the pathology world as well. Some examples such as papillary thyroid cancer, tubular carcinoma of breast. And I think even in the world of prostate cancer, I think most urologists have an understanding that the T1A situation in a TUR, if you find a small amount of low-grade carcinoma, that's really not a cancer in that sense of the word. Now, this is the problem we're faced with lots of times. This is the minimal cancer. So this is a tumor that's a Gleason 3+3, the tiny little clusters of atypical acini in the middle, less than 1 millimeter, one core less than 5%, the truly minimal cases. In my practice, this is accounting for about 12% of cases. 1 in 8 cases fit into this category. So these are the ones I almost apologetically diagnose as cancer. These tiny little microfoci. I really feel bad about diagnosing them as cancer, but I think from the point of view of the true meaning of carcinoma, they are a neoplasm in that sense. And remember, the big problem for pathologists is looking at these cores is we only have a tiny sample of what we're looking at. So if you do the calculations as to what the volume of a needle core is, and you look at an extended biopsy set of 12 cores, that's about a 0.5% of the prostate volume that we're looking at. So we're really not 100% sure about what's going on elsewhere in that gland. So I think that Gleason 3 there is a lot of heterogeneity. So we got to do a lot more work from a pathological perspective. Clearly there's cytological heterogeneity. We can see a case like this where you have very high-grade nuclear changes, very prominent nucleoli, and cases where they're not prominent at all. And as well, there, as been mentioned by a lot of the speakers so far, there's a lot of other things that are happening in terms of the molecular genetics and the personalized medicine aspect. And I think that's going to be a huge thing in the future as we move towards trying to identify some of the cancer-specific genes and some of the protein products that we can look at by immunohistochemistry to try to identify within this Gleason 3 category which tumors are the bad ones. Now, what about son of Gleason? This is the last part. Well, I think we got to turf the Gleason score. The Gleason scores go from 2 to 10. That doesn't make sense anymore. You're trying to talk to patients and you're telling a patient, well, you have a Gleason 6, which is a low-grade tumor, but that's sort of in the middle. So we got to get rid of this whole concept of the Gleason scoring. And I think maybe a grade grouping might make a little bit more sense. And this is just one proposal that's out there. And we still keep the Gleason patterns. I think they're very useful, those 9 Gleason patterns that we saw originally that Gleason described. So in this model here, we have a Gleason grade 1, where we have less than or equal to anything that's Gleason pattern 3. We have 2 that's 3 with a small amount of 4. Maybe this is something Laurie's going to talk about with respect to this active surveillance in this category, because we're seeing a lot more of these cases where you're calling it a Gleason 7 where there's a very tiny amount of 4, less than 5%. This has really gone up dramatically over the last 5 to 10 years. Then you have a category 3 with a large amount of Gleason 4. Then you have category 4 where you have a pure 4 or a 3-4 and a very small amount of 5. And then you get into category 5. These are the uniform bad actors over here, these 4 5s or 5 pures. So that's one possibility in terms of the son of Gleason. Another possibility that I've been thinking about a lot is this concept of trying to do a quantitative grading. So you basically look at the relative percentages of patterns 3, 4, and 5. Then your range would be anywhere from 100% 3 with 0, 0, 4, 5 to 0, 0 for 3, 4 and 100% 5. Continuous variables. And if you have your core links, you can actually develop a relative volume, so you can make a quantitative grading system as well. So I think that might be something that we could look at in a more quantitative way in terms of prognosis. So just to finish up, there have been significant Gleason upgrading has occurred since ISUP 2005 Consensus Conference and will continue to occur based on the subsequent changes. There's a need to stabilize grading for future studies and clinical practice. And I think, for people that are doing clinical trials, it's very important to have a central review and to have a pathologist sort of do your review, or else you might be dealing with markers that are all over the map. I predicted the demise of the classic Gleason score in favor of new Gleason grade groupings. I think we need to explore the heterogeneity both within the Gleason 3 and 4 category as we go forward in the future. And we're probably going to recognize that some Gleason 3 carcinomas are not really cancers in the true sense of the word. And the key thing is to get the message to the patients that that's really the case. Thank you very much.